Hi there once again, Dr. Krish Bab here. I'm here today to discuss the blood supply of the gut. The topic repeated ad nauseum in all medical colleges, hospitals, institutions. Thought I'll revise with you with a twist. Embryologically, the gut is made up of foregut, midgut and the hindgut. You all know very well. Supplied by the celiac artery, superior mesenteric artery and the inferior mesenteric artery, respectively. The celiac trunk is the first branch to be given off from the abdominal aorta at the level of T12 vertebra. Short, thick trunk, it divides into three branches immediately. The left gastric, splenic artery and the common hepatic artery. Together these arteries supply the foregut. That is the entire stomach, duodenum up till D2, spleen, most of the pancreas, liver and the gallbladder. In surgical practice, celiac is not encountered most of the time. In a very rare syndrome called as a median arcuate ligament syndrome, wherein the median arcuate ligament of the diaphragm causes kinking and obstruction of the celiac trunk. Very rare. It's a challenge to manage that syndrome. Of course, the challenge is going to be to the vascular surgeon who is going to revascularize the kinked celiac artery. Then comes the superior mesenteric artery, given at the level of L1 vertebra. It is the lifeline of the entire small bowel, ascending colon and right 2/3 of the transverse colon through its various branches, you all know very well. Superior mesenteric artery is also involved in a very rare syndrome called as SMA syndrome, same name. The angulation from the abdominal aorta, when it becomes very acute, the third part of the duodenum gets obstructed. When the obstruction is severe enough, it is surgically intervened in the form of duodenojejunectomy. SMA is the victim of mesenteric ischemia, more importantly. You got ischemic colitis also, but ischemic colitis is managed most of the time conservatively, but not so in the case of mesenteric ischemia. Can result due to acute embolism, acute thrombosis of the superior mesenteric artery, thrombosis of the superior mesenteric vein, and the more problematic non-occlusive mesenteric ischemia. All these four clinical syndromes present with a catastrophic surgical emergency. Only the ones with the superior mesenteric vein thrombosis have better survival rates. Then you got the inferior mesenteric artery, given off at the level of L3 vertebra. It is the artery of the hindgut, the remaining portion of the transverse colon, descending colon, rectosigmoid, up till the upper third of the anal canal. This artery is commonly encountered in surgical practice when you're doing your laparoscopic anterior resections, laparoscopic abdominoperineal resections, laparoscopic rectosigmoidectomies. So the inferior mesenteric artery is clipped before the division. Of course, after identification of the ureter. Inferior mesenteric artery also gets involved in abdominal aortic aneurysm surgery because it is given off at the level of L3. There is a clear and distinct possibility of colonic ischemia ensuing after surgery because that part of the aorta is resected and the inferior mesenteric artery has to be reimplanted. That is why it is of importance to aneurysm surgery repair also. Thank you once again. And don't forget to send your feedbacks. Your feedbacks are important in me continuing my discourses in human sciences. Of course, I do topics on humane sciences also, which will be of interest for you as well. Thank you.